Thank you, and good morning to you all. If I just go forward, I'll get the first one. Is that correct? Perfect. So I am here representing the American College of Surgeons, and I was asked to give you the top 3 challenges and the lesser 4 or 5 challenges on the college. And I therefore will concentrate on the challenges themselves and perhaps the origin and the cause of the challenges rather than the potential solutions that they may be. The 3 main issues that we came up with, and when I say we, I mean Dr. Sachtiva, who is our Director of Surgical Education at the American College of Surgeons, and myself, are first, the impact of healthcare transformation as it's going on right now in the US on education and training. The second one is a lack of autonomy by senior trainees, and the third is work hour limitation. So let me expand in each one of these 3 for just a second. Healthcare transformation has a significant emphasis on safety. It has a significant emphasis on outcomes. It has a significant emphasis on transparency. And by transparency, I mean that the patient ought to know who is doing what at the time of operation. It has a significant emphasis on efficiency, and that is to achieve whatever we're going to achieve in the fastest possible way. And therefore, with the complexity of systems and patients that we have, this has resulted in a decreased participation of trainees in operations. As you look at safety, at outcomes, and transparency, efficiency, and so forth, and the complexity, you realize that the trainees, the attending physicians, as we call them, or the consultants, as you call them, in this side of the Atlantic, have taken more of a role in doing that. The second challenge that we have, in part, derives from the first, the lack of autonomy. As several surveys that the College of Surgeons has done in the US has shown, graduating residents, which for us is usually somewhere between 5 and 7 years after starting training, of clinical training, the attending surgeons today must be involved in all aspects of care, from admission, decision-making, and particularly in the operating room. Billing is not permitted unless the attending is involved. And with the system that we have in the US, if we are not directly involved and write and document and sign that we are involved, we cannot bill. Hospital compliance does not allow us to not bill. So not billing is not an option there. And therefore, this leads to a greater involvement of the attending physician in every aspect of the patient's treatment, including in the operating room where the attending physician is present all the time. Therefore, the trainee does not get, as we used to get in the past, the chance of making some decisions for herself or himself and seeing the results of those decisions as they are carried through. So this erodes the competence and the confidence of these trainees when they graduate, because they have not been in a position to make those decisions and to see what happens with that. And the third is the work hour limitations. Now, I come here and I'm a little bit reluctant to talk too much about work hour limitations because we limited them from 120 average to 80 average in 2003, and then in 2011 decreased further the working hours for the residents to a minimum of 16. So if you look at what has happened on our side, the working hours at a 5-year period have been decreased now to 19,600 when we used to have a number that was greatly superior to that. If you look at what the recent poll of the directors have had, the greatest impact here when you have this type of limitation is, of course, on the opportunity, because the individuals are not in the hospital at the time, and in the continuity of care of patients. A recent poll of the program directors in the United States show that while the majority approved, on the right side column, of almost all aspects of the changes in work hours, there were 2 that were clearly against, and that is the number of hours that the residents, the PGY1 are present in the open rooms, and those are postgraduate level 1 residents, and the fact that the residents are not available for continuity of care. So lesser problems, as we see, are continuing trends favoring subspecialty training with shortage of general surgeons in the workforce. So as we need more and more generalists, we're producing less and less. And this addresses really the issue that Richard was talking about. Can we possibly train for the job that the residents are going to do? And I submit to you that that is a very difficult proposition, because we don't know 5, 6, 7 years down the road what is it that these individuals will do, but ideally we should. Decreased funding for graduate medical education, conflicting priorities of surgical faculty resulting from pressures to generate additional revenue at the expense of educational endeavors. We are seeing that, if you remember my first slide, as healthcare transformation has led hospitals to become more efficient, more transparent, more focused on outcomes and value, specifically value being outcomes divided by cost, there's a big conflicting priority, because attending time is not allowed, if you wish, for the continuous feedback that is generated by the evaluations that Richard was talking about as well. And so that is a major problem for us. Support for faculty development to convert them in the appropriate educators that were just recently discussed. Dealing with constant innovation on techniques, instruments, devices. This is an idea that is very difficult when everything is constantly changing, to establish a platform for training before something else changes and before we have even trained on the new change of technique. Dealing with changes in the boundaries of specialties, that is, when vascular surgery is now being practiced by interventional radiologists and by cardiologists and so on and so forth. So how do we deal with that? And surgery becoming less relevant in the treatment of disease. So there are a lot less operations of the traditional type that we have today to train people. So with that, I would like to stop, and I thank you for the opportunity to give you my perspective.